not too late. I have not had any major questions come up over these weeks. Everybody seems to be able to do it fairly smoothly. So join us in this work. We really appreciate it. So I have started our recording, and so we'll get started with today's webinar. I am very excited to have Dr. Ravi Patel. He is our neonatal Dr. Patel's interests include clinical research and quality improvement. Dr. Patel received his medical degree from Medical College of Georgia at Augusta University. Then he obtained his Master of Science in Clinical Research, as well as his fellowship training in neonatology at Emory University School of Medicine. Dr. Patel's research interests include necrotizing enterocolitis, blood transfusion, and caffeine therapy. Please join me in welcoming Dr. Patel to present today on updates on necrotizing enterocolitis.
Great. Well, thank you so much. Can you hear me okay, Laura? Yeah, it's great to see everyone, and it was fantastic to see the center's contributing audit. So thank you really a lot. It'll be helpful, I know, for Dr. Pinion and the GaPQC to think about using and understanding where we are and how we can improve on a key aspect of kind of care of parents and their babies. So I thought today we would talk about some recent updates on necrotizing enterocolitis. This has been a topic that's been front of mind for a lot of us that practice in neonatal units. And there's also been a lot going on nationally. And so I thought this would be a good opportunity to share with the GaPQC some of these updates and also to perhaps have some time for questions and a discussion on this. I do have a couple of disclosures. I serve on a data safety monitoring committee of an ongoing trial of an investigational probiotic product, and I am on the scientific board of Noviome, which is developing therapeutics for NEC. And I will be briefly mentioning probiotics, and these are currently not FDA approved for the prevention of any neonatal disease. So why necrotizing enterocolitis? And for those of you that may not be as familiar with this disease, this is typically a disease that affects premature babies, but it can also affect infants born at term, particularly those that have other risk factors such as congenital heart disease or gastrointestinal tract abnormalities. And it's much more common the more immature an infant gets. So the more premature, the higher the risk, with the greatest risk in those infants that are less than 1,500 grams at birth. But it's also a disease that can strike infants suddenly and quickly. This is a picture of Micah Canvasser, who is just before he developed NEC, he sadly passed away from the disease. And I use this with permission from his mother, Jennifer Canvasser, who, for those that were at one of our prior GaPQC meetings, you heard from Jennifer speak about Micah's story and about the foundation of the Next Society. This is a group that's really been patient advocacy group that's trying to advance clinical care, advocacy, and research and to prevent this disease. That's really, I think, a great, wonderful organization. The website I put here on this slide, if you want to learn more about the Next Society. But this is, I think, the reason for this centering the talk today on updates is as we think about this, this is really a challenge, and I'll share some data in Georgia about the impact it has for those of us that care for infants in the neonatal intensive care setting, and also highlights really the importance of the work for this collaborative and the work that all of you do in your hospitals as it relates to optimizing newborn nutrition, because this is one of the most important areas to target to try to improve the outcomes related to this and reduce the risk of NEC. So I shared this. This is actually a study, and I know it's a little fuzzy, but I would encourage for those that might, and maybe we could circulate the link. This was published by the Vermont Oxford Network this year that looked at kind of trends in a lot of outcomes in neonatal intensive care. And what it showed is that if you looked at a lot of things that a lot of the common problems and complications of prematurity, that we really made a lot of gains in these outcomes kind of in the mid 2000s. Over the last kind of couple of decades, you'd seen decreases in rates of many of the neonatal complications, but really over the last 10 years or so, we've stalled. And you can see this for any given gestational age baby and the rates. It's higher for those babies that are more premature. For example, at 24%, about 10% of babies develop necrotizing enterocolitis. At 28 weeks, it's about 4%. But really, we have not made a dent in the needle in terms of reducing the burden of this disease over recent years. So while we had made some progress, that progress has stalled. And this is actually for a lot of the other outcomes in this study, a similar pattern appears. And I think this highlights really the opportunity for quality collaboratives as we try to tackle these problems and diseases and how we can try to move the needle. I think this highlights the opportunity, but also the challenge in front of us. What about death from necrotizing enterocolitis? This is a study published by one of my neonatal colleagues, Dr. Maddie Wolf, and this was published last year, looking at in the United States the burden of related death. And in this study, we showed that about one infant dies every day in the United States from necrotizing enterocolitis. So this is, although not very common when we think about other complications, this has a substantial burden when we think about an infant loss every day from the disease. And this is looking at mortality using data from CDC that shows the same pattern, that we kind of saw a rise, unclear why this is, but kind of a rise in neck-related deaths in the United States. And then it fell. But really, we've really slowed in terms of our progress in reducing deaths from this disease in the last few years. You can see the slope of this line is flatter. So then how are we doing in Georgia? So in the same paper, when we look at kind of the states and the neck-related mortality rates across U.S. states, you can see here that we are one of the higher states. We were actually the third highest state when it came to neck-related infant mortality in the U.S. And some of that is related to just more higher rates of prematurity and the work we need to do on reducing preterm birth, which is a big risk factor. But then even among preterm infants, we see this burden. And so I think highlights the call for why optimizing newborn nutrition is really important. And the work we're doing in Georgia, I think tackling a problem we see. And in Georgia, when we look at causes of death, neck itself has always, historically been one of the major causes of infant mortality in our state. So with that framing, I'm going to talk about some of the updates as I thought this would be a good opportunity to share with the GaPQC some new updates as it relates to enteral feeding practices and the risk of necrotizing enterocolitis, and also about just an update on the use of probiotics in preterm infants, as I know there are some units in our state that were using that and where things stand with those. So first, reviewing the scientific evidence on enteral feeding practices and risk of necrotizing enterocolitis. And I highlight this statement. This is from the American Academy of Pediatrics. This is one of several statements on enteral feeding, but I think relevant for the babies at highest risk for necrotizing enterocolitis, the very low birth weight infants. This is the lead author here is Dr. Meg Parker. Dr. Poindexter is also one of the co-authors on this statement, along with several other folks, including Dr. Lisa Stallwagen, who's the kind of incoming president of Hambana. And what the statement highlights, and Dr. Parker presented this a few years ago at our GaPQC meeting just as it was being released, but I think it's a good statement and refresher for the group to highlight the importance of human milk as the optimal nutrition for very low birth weight infants and decreases the risk of significant complications of prematurity, most notably neck. So that's front and center in the statement. I think highlights really the efforts as we think about in our GaPQC, as human milk is the first feeding, we know that that's relevant not only in the, for kind of all babies in this collaborative, but why it's important, why we do it is right here on the first line. And then pasteurized donor human milk feeding is recommended for very low birth weight infants when mother's own milk is not available, is insufficient, or is contraindicated. There are racial and ethnic disparities in the provision of mother's own milk and pasteurized donor milk for very low birth weight infants, and that human milk frequently has to be fortified to meet the nutritional needs of very low birth weight infants. And I think one of the areas I want to highlight is, as we think about quality improvement, one of the ways we can try to address disparities and move the needle in parental milk provision is through collaborative work. And I know that there are groups here that have worked on that, and as part of this most recent audit, we'll have some data on this. But this is, thinking of improving the quality of care in your NICU is one of the real ways we can try to address some of these disparities and work towards equity. So I also want to highlight some new events that came about just a couple months ago. In August of 2024, at the request of the U.S. Secretary of Department, the Secretary of the Department of Health and Human Services, the National Institutes of Health, and specifically the branch the National Institute of Child Health and Human Development was tasked with convening necrotizing enterocolitis and preterm infant working group. And this group advised the Council for the NIH. And really, the task that was given from the Secretary of HHS was to assess the scientific evidence regarding enteral feeding practices in premature infants and factors that may protect against or increase the risk of necrotizing enterocolitis. And I thought it'd be a good opportunity to highlight some of the key findings from this work group and what it came up with. I had the good fortune of chairing this work group with Dr. Bonnie Maldonado, who's at Stanford, and it involved a number of representatives and experts in the field, along with representatives from various organizations, including the American Academy of Pediatrics, the Human Milk Banking Association, North America, and other groups. So some of the findings, and if you're interested, there's a large report that you can scan the QR code and look at. But I think the kind of summary of findings from this report were that some of the aspects of feeding and development of NEC are unclear, but that the available evidence supports the hypothesis that an absence of human milk in an infant's diet is associated with a higher risk of NEC. So part of the reason we think in our GaPQC efforts on human milk as the first feeding, and the emphasis is that there's clear benefit. And if you don't get the benefit of human milk feeding, then that is associated with a higher risk of NEC. But we still have work to do on understanding kind of the mechanisms that cause NEC and what are the specific components or beneficial aspects of human milk that may prevent it. There have been a number of studies. Human milk is an incredible kind of biologic, has incredible biology in terms of the factors that might help to reduce the risk of NEC. There are factors like epidermal growth factor, lactoferrin, human milk oligosaccharides. There's also some bacteria that all of those things that may be involved in terms of providing protection against necrotizing enterocolitis and also improving the health of infants who receive it. We do know that even with the provision of that even with human milk feeding, that babies still develop NEC. And so I do think that it's important as we think about this disease that it's important. Human milk is probably the most important strategy in terms of reducing the risk, but that doesn't fully eliminate a baby still that are receiving human milk are fed. That are fed still develop NEC. And then in terms of some of the gaps of knowledge, I'm going to touch on some of this in the next few slides, that there's some gaps of knowledge about the optimal nutrition and feeding and how we fortify nutrition, particularly for the preterm infants that often need fortification of human milk, those very low birth weight infants, and some of the uncertainties regarding that. And also that given that a parent may not always be able to produce enough milk for a preterm infant, research is needed to find ways to enhance milk production, optimize the beneficial components of human milk, and reduce disparities that impede lactation and pumping for parents and access to donor milk. And I think while this work group was focused on research gaps, I think this is also a call to action for quality collaboratives to say, what are the ways we can do this? What are the strategies for GaPQC and others, and I'm going to touch on this in a little bit in terms of ways to target some of these areas where we do have some guidance in terms of enhancing milk production and reducing disparities that may occur. So there were some working group recommendations. I'm not going to go through all of these outside of kind of they were grouped into overarching recommendations in terms of reducing prematurity, and then trying to improve tracking of NEC, and then making sure that perspectives of affected families are incorporated in research. But I'm going to tie some of the research recommendations and some of the uncertainties as it relates specifically to optimizing neonatal nutrition and nutritional support for preterm infants and feeding practices. So regarding support and how we nourish preterm infants, there was a lot of kind of discussions about understanding the specific nutritional needs of those babies, both preterm infants and those that survive NEC. And we know that growth can be a challenge for particularly the most premature infants in the neonatal unit, and how we can address and meet the nutritional needs. Strategies to support parents' milk production and lactation techniques for preterm and term infants. And then also some of the areas of how we collect, process, store, dispense, donor, and parent milk, and how some of those approaches may impact nutritional content and intestinal health. At the same time, I think when we think about these research opportunities from the GaPQC and quality improvement lens, I think these are also areas where you think of how can we support parents' milk production and lactation for preterm and term infants in the NICU, and potentially policies and guidance in terms of how we in our centers have guidance on collection, processing, storing, and dispensing of donor and parent milk, and thinking about how we have this guidance and whether we do and what's in there. And in terms of feeding practice, important need for clinical trials and ways we can test and develop promising drugs and biologics to prevent or treat NEC. And also the role of implementation science so that we can reduce some of the disparities by ensuring that we can implement the available knowledge we have today to prevent the burden of this disease, and how we can better educate families in the NICU before or even before delivery in terms of the risk of conditions such as NEC. Now, one of the things that I think is really important as we think about optimizing newborn nutrition, and this is one of the studies that shows it beautifully, that was published in 2009, is when we think about the risk of necrotizing enterocolitis, the human milk is important, but the dose also matters. And so this is a study that was done in the NICHD Neonatal Research Network that looked at over 120 days. Each of these curves is the risk of a baby developing necrotizing enterocolitis, or surviving without necrotizing enterocolitis. So the higher the curve, the higher the survival without necrotizing enterocolitis. The lower curve, the higher the rate of developing NEC or death. And then each of these curves corresponds to the percent of human milk that an infant received over the first 14 days, from 0% to 25%, 50%, 75%, or 100%. I think this shows ideally we want 100%, but even if you can achieve or improve on the provision in the first 14 days, you can really reduce the risk compared to the population of babies that receive no human milk. And so as we think about strategies to try to ensure and increase the provision of human milk, I would say not only for the first 14 days, but beyond, trying to increase the dose is really important. I think a lot of places have made a lot of gains in terms of addressing this. And one of the things as we think about this is a great infographic, thanks to Claire Eden and GaPQC for developing this, is as we think about what are we the guidance we're giving, and how can we make this actionable in terms of ensuring we can increase parenteral milk provision for babies in the NICU. I think these are very tangible, actionable things that you can apply in your unit. So expressing milk at least 5 times a day by day 5, that's a very good target to work on, 5 by 5. Trying to have one of these be in early AM and not avoiding longer durations, longer gaps between pumping sessions. And really the target here is saying, how can we ensure this wonderful protection that human milk provides to babies in the NICU, and really ensure that it persists, because we know from work that other quality collaboratives such as Massachusetts has done that human milk provision really starts to drop off after postnatal day 14, even if it's provided early, and we want to try to think about sustaining that. So great infographic. Hopefully some of the centers can think about how we might make this actionable in the neonatal units. Now, parenteral milk is not always available, and so in that situation, when we think about feeding, donor milk is recommended by the American Academy of Pediatrics, and I think this highlights an important. This is a trial that was published this year that compared in situations of extremely low birth weight infants when parenteral milk is unavailable, the use of donor milk versus preterm formula, and you can see that the risk of NEC was decreased by about half. You can see a 5% absolute decrease. So for every 20 babies that received donor milk instead of preterm formula, 1 fewer baby developed necrotizing enterocolitis. And this was a study that was done at the NICHD Neonatal Research Network, and I think provides important information on provision of donor milk. So I think the goal is, of course, parenteral milk, but if that's not always available, or may not be available at the time infants starting to feed, then this should be a key target. And I think most of the NICUs in Georgia are providing that. But if you're not, this is an opportunity to, if you care for babies that are at risk of NEC, this is one of those opportunities to, rethink the availability of this, or ensuring that there's access to this. I highlight California has really tried to push this as saying they want 100% of all the NICUs in California to have equitable donor milk access. In their surveys, it's pretty good. 88% of NICUs in California offer donor milk, but that means 12 NICUs don't. And so I think they've made a push to say the 17 hospitals in the state where that care for preemies in the NICU that are at risk for NEC. How can we try to get donor milk being routine to ensure the babies have access to that in the NICU? And I know we've surveyed that in the GaPQC, and so far we've the data we have is that most of the participating NICUs provide donor milk. But if you're not, this is a great opportunity to, in a collaborative, or you might work in settings where you occasionally take care of preterm infants, an opportunity to target, and we're here to help for those sites that might be interested in this to reach out to the GAPQC. And then finally, bovine versus human milk-based fortifiers. This has been a big topic of interest, is because human milk frequently requires fortification to meet the nutritional need, particularly for very low birth weight infants, those babies less than 15 grams, that is achieved often by fortification or addition of fortifiers that add protein, calories, and other nutrients to the human milk. And there's been some debate about whether that human milk fortifier should be based on derived from human milk, so a fortifier that comes from human milk. This is currently marketed as prolactin, or bovine-based fortifiers that come from cow-based milk. And when you look at the trials, I show this that when you look at when babies get either parental milk or donor human milk, so all babies, their diet is achieves either parental milk or human milk, how much of an additional benefit do you achieve with the provision of a human milk-based fortifier? It looks like there's not a clear benefit in reduction of NEC when you look at babies who are already all getting human milk feeding from either donor human milk or parental milk. And that contrasts some of the earlier studies where fortification was tied with also giving donor milk versus preterm formula. And so I think this highlights that there's probably some uncertainty. I imagine there's going to be more kind of data that looks at this, but it's not clear that the use of a human milk-based fortifier when you provide donor human milk or parental milk feeding, it has a clear effect on reduction in NEC. Now, there might be other benefits, and I think groups are going to look at the data as a whole, and so stay tuned for kind of more information on that. So next, I wanted to provide a few updates on probiotics in preterm infants, and I thought I would start with reminding us that neonates don't have sterile intestinal tracts, and the colonization of the intestinal tract after birth is really a very important process in the life of a newborn, but particularly in a baby who's in the NICU, where the gut microbiome might be important, and studies have shown that this is really important in the risk of in necrotizing enterocolitis. And if there's an imbalance or kind of unfavorable balance of bacteria, that might set babies up for intestinal inflammation and development of necrotizing enterocolitis. So I wanted to start with guidance on the use of probiotics. This is by the lead author. This is from the American Academy of Pediatrics. It's Dr. Poindexter. And AAP current recommendations are that they do not support the universal routine administration of probiotics to preterm infants, particularly those infants that are less than 1,000 grams at birth. But the same guidance does give kind of recommendations for centers that do choose to use probiotics to select preterm infants, and recommendations such as discussing the potential risks and benefits of this therapy with parents, and considering a formalized informed consent process, having local guidelines, and conducting surveillance. So for centers that do decide to use this, I think this is important guidance. And to be aware of the regulatory standards for commercially available probiotic products as dietary supplements. I'm gonna touch on that in just a little bit. And then centers that do use it should carefully document outcomes, adverse events, and monitor safety. And so this is from the AP and gives some guidance in terms of where the recommendations are, and if centers do choose to use it, some guidance for those centers. The World Health Organization also has guidance, and I highlight they actually provide guidance on a number of aspects, but for probiotics, the World Health Organization says probiotics may be considered for human milk-fed preterm infants less than 32 weeks gestation. This is a conditional recommendation based on moderate certainty evidence, and this was published last year. And then the Next Society mentioned earlier also has some guidance, and this is that probiotics can be considered as a strategy to reduce risks of NEC and death in very low birth weight infants. That there's growing awareness of this, and therefore that sites, even if you choose not to at least be that be ready to have some discussions with families about the use and then for sites that do use it to really have careful data collection to track or understand the effect of probiotic use. Now, why about this discussion of probiotics? Well, the reason is because when you look at the prevention of necrotising enterocolitis, human milk feeding, I think, is the most important. And if parenteral milk is not available, donor human milk, those are really the key strategies. But in clinical trials to date, and a fair number, this is a review of 106 clinical trials. So a fair number of studies have actually been done, about 25,000 preterm infants enrolled, that when you look at probiotic supplementation, these trials, that they showed reduction in all-cause mortality, in the risk of NEC, and maybe some more modest reductions in infection or sepsis, and also some reductions in feeding tolerance, days to reach full feedings, and shorter duration hospitalization. So there are potential benefits, and maybe some larger benefits for those that are multi-strain products as opposed to single-strain products. There is some limitation with these studies. Many of these were done outside the U.S. in various settings, and so that there are some kind of limitations in terms of comparing or combining different types of studies. But I do think that this provides evidence of why probiotics might be important. And in the United States, about 30% of NICUs were using that. I think I'll tell you, share why that's really been reduced recently. But in studies where NICUs were routinely using that, these are two large studies that showed that in babies who received probiotics that there was a lower risk of death. This was published last year by the Vermont Oxford Network. Lower risk of NEC, and then another study that says if babies who receive probiotics compared to not receiving that, this was a study from 289 U.S. NICUs, that there was lower risks of NEC and death and not clearly bloodstream infection. So kind of data that you would say is consistent with what was shown in the clinical trials when infants received products. And this has been observed in a lot of U.S. centers. So I share here kind of studies of various NICUs here in the United States reporting their experience with the use of probiotics. And what it suggests is that those centers that most of these went from a period of no probiotic supplementation to probiotic supplementation. They looked and said, what happened with our NEC incidence? So if you're a NICU that has a relatively low NEC incidence of 2%, 3%, you may see, you may not see a large reduction, but for NICUs that tend to have a high incidence, you can see that most of these NICUs, when they started probiotic supplementation, they saw a reduction in NEC rates. And in these studies, at least, there was no risk of probiotic-related sepsis. Now, the trends in use in the U.S. NICUs really started to be rising. There was a rising kind of number of NICUs. About a third were using probiotics if you looked at U.S. centers based on surveys. Some of these units were obtaining consent. Others were actually about a third of NICUs that weren't using it were considering initiation. Although with a pretty variable number of commercial products and different brands. And so that's one of the challenges is there's a whole variety of different supplements that are available, and these were variably used across NICUs. And then things changed pretty dramatically in September 29th of last year. And this was an alert and a warning that was issued by the Food and Drug Administration. This was an infant who developed invasive disease in preterm infants. This was a baby who developed a Bifidobacterium infantis invasive infection after receiving this. And based on this, the FDA issued an alert. And following this and data we've looked at and surveys that have been done, essentially probiotic supplementation has really stopped in most NICUs here in the United States. I think there's still a few that are providing that, but most NICUs after this warning and some of the guidance provided by the FDA have stopped using that, even with kind of some of the data I just showed you about the benefits that may exist. This is a potential risk. It's very uncommon. The risk of invasive infection has been reported, but this was an infant who developed it. And of course, if you give live bacteria, there's always the risk that the live bacteria can get into the bloodstream, either through the gut or through contamination and kind of access through a vascular catheter. Now, some of the kind of challenges with probiotics is that they might be a supplement, and that's how they've been used currently in the United States as a dietary supplement. And these are generally kind of supplements, just like if you went to the supermarket and you saw on the shelf supplements that are available. They're not drugs, and drugs kind of come with a different class called live biotherapeutic products. And these probiotic drugs, there's currently no probiotic drugs for preterm infants, but these drugs come with kind of more specific requirements by the FDA. And so most of the products, as we think of regulation and why they're not approved, they're because they're dietary supplements that might supplement the diet, just like you might supplement preterm infants with other supplements. Probiotic drugs, they're termed live biotherapeutic products, and those are things that are being developed but currently aren't available. I bring this up because this has been, as we talked about updates in NEC, and for all of you to know what's going on. There was a recent meeting. This was just at the end of last month at the Food and Drug Administration, the Centers for Disease Control, and the National Institutes of Health convened on the use of probiotics or live biotherapeutic products and the risk of NAC. And this was a meeting that involved some of the discussions on the use and some of the balancing of kind of what's known about the benefits and regulation. The American Academy of Pediatrics was present at this meeting and kind of urged the FDA to expedite the review of probiotics and allow NICUs access and methods to be able to use it if they choose to do so. The Next Society also presented, and you can look on their website for a formal statement about their comments. Also, a drug company that's trying to develop a drug formulation of probiotics shared some of that data. All of this is publicly available. But I share this for those that might be interested, that this is an opportunity for the FDA to hear from you and for public comment. This was a federal meeting, and so as part of that, there's a federal register for public comments. Here's a QR code to that link. And so if you go to that, you can submit public comments, have up to November 25th. So if this is a topic that may be important to you or others at your center, this is one opportunity for the FDA to hear from you in terms of probiotic products to prevent necrotizing enterocolitis in very low birth weight infants, and you have an opportunity here to submit comments that that can be considered by the FDA. So I just wanted to mention that as an update, and it may be as a result of this that there may be updated guidance that comes out. I think we have to wait and see from the FDA on probiotic use. So with that, I'll finish up and happy to take questions that the group may have. And if you're interested, I'm happy to share these slides as well.